So once your patient is deteriorating, once again you will be keep on doing ABCD protocol till your seniors arrive, right? And other thing you can do in recommendation, you are going to document the things uh, what you have done so far. And once your patient is stable, you can counsel the patient or the problem, and you can give the safety netting and warning sign for the next time, right? So these are things you can tell the your examiner can ask some differential question, and he can ask the relevant question. So it depends on the station. So this is all about ABCD approach. So if you have any question, you can write in the chat box. Otherwise, we are going to discuss one case, asthma and anaphylaxis. I believe you have written something in the chat box before. I couldn't see those texts. So if you want to ask anything, we can discuss. Otherwise, we are going to discuss one more case. SBR is for telling the examiner at the in for 2 minutes. Yes, SBR approach is whenever you give handover to any colleagues or any consultant. So you have to follow the SBR approach. S for situation, B for background, A for assessment, R for recommendation, right? So just bear in mind that you are following the SBR approach and you need to give the handover to the examiner, right? So this is the Simman. Maybe many of you have seen this before. There will be monitor. You will be standing here. This is the stand nearby Simman. So whatever you are doing, just involve the patient, look at the monitor, take the feedback. How are you feeling now? Is still not the same. Go with the next option. And while removing the duet, take the permission. Ask the patient that you will ensure the privacy. Once you finish your examination, you will put this duet over the patient to maintain the dignity and respect, right? And maybe to prevent hypothermia condition by putting duet back to the patient. So believe me, if you are doing these things, and what is most important thing in the station, it's your confidence. So you are not hesitant, you are not uh, you are not uh, nervous, or you are confused about the station. If you are doing things very confidently, and you are handling the Siemens emotions very confidently, believe me, you will get very good marks. So this is the Simman you will see on your exam day, and it's very constant station. So there are a few constant station which you need to practice on every day. These constant station is Simman, procedures, examination, prescription, BBN cases, LGBT cases, angry patient. So PLEP 2 is about being smart. So if you are prepping your PLEP 2 exam, being smart, so you will be in good position to get it across very easily. So please repeat the recommendation part again. So in recommendation, so what's your recommendation? So you believe your patient needs admission. So you can say, I'm going to involve my senior, I'm going to involve the critical team, and I believe my patient needs admission at this moment. Is not, yeah, you can say, I believe my patient needs observation for next 4 hours. If condition is not getting better, we are going to admit this patient. So in recommendation, you can give some impression. What's your further impression or further management plan, right? What do we do if they don't write in the task to talk to the examiner after 2 minutes? So if they don't write like this, so keep doing your management with the patient. You need to tell the patient what's been going on and what's your further management plan. So at this moment, after 6 minutes, maybe your patient will be stable. So you can discuss some management options. You can tell the patient that, see, your condition is critical, so you need to be stay in the hospital. Is it okay with you? Right? So there will be 7-step management you need to discuss with the patient. when to make sure the patient about his privacy. When you are doing the chest examination, when you are doing the chest examination, you can say, I'm going to examine your chest, and for the purpose of examination, I'm going to undress you, and I will ensure your privacy, and chaperone will be with me. Right? Any other questions? If not, then we can discuss one more case. Okay, let's discuss one asthma case.
नहीं वो कर सकते.
So just look at the talking mannequin. A stable patient can be if urosepsis, upper GI bleed, acute limb ischemia, talking mannequin, asthma, anaphylaxis, post-UTI, PPH. Unconscious patient can be hypoglycemic and death confirmation. So death confirmation is not coming these days, but it can come at any time. You need to go once about this station. The stable patient, you need, if patient is stable, but these stable patient, still patient will be unwell and unable to give you history. So you need to follow the ABCD protocol in all these stations, right? In acute limb ischemia, you can take the focus history, then you can do the examination, that's fine. In urosepsis, you can apply the same rule. But in other station, patient will be acutely unwell, so just use your rational reasons and do it appropriately, right? So this is acute asthma, acute exacerbation of asthma. You are referred to in the emergency department. Mr. Adam Jones is 30 years old man who is present to the hospital with short of breath. Take a focus history, assess the patient, discuss management with the patient. Okay, so see, in this task, they haven't write what where you need to discuss. So you need to discuss management with the patient. So if it's right, you need to discuss management after 6 minutes with the examiner. So you don't need to discuss it with the patient, right? So in this station, you need to go with your task, discuss management with the patient. So you don't need to go to the examiner. If examiner interrupts you in between, only then you can answer the examiner's things. Otherwise, follow your task, discuss management with the patient. So setting is Simman. Initially, oxygen saturation is 88. After giving oxygen, it will improve to the 92. So see, after giving the oxygen, you need to look at the monitors. So monitor will be beside the Simman. During the examination, saturation can drops against to 88, which means you need to do another second step of acute exacerbation of asthma. After all treatment is mentioned, the situation changed to 98. If you are doing all steps appropriately, at the end of station, your patient will be stable and you will get good marks.
Dr.
If you are
Mac,
fall, yeah,
yeah, I think the screen is stuck because we can't see the slides.
you can't see any slide.
Yeah.
Oh, just 1 minute. Can everyone see the slide?
Yes, now it's visible.
So,
Thank you.
so I have shared these Dr. Sampson's notes in our group. So we were friends. We have written these notes while we were attending the academy. So you can go through and you can get benefit of these notes as well. Okay, so this is about the acute exacerbation of asthma. You need to discuss management with the patient. In initial setup, patient will be acutely hypoxic. Patient will say, doctor, please help me, my asthma is killing me, right? Patient is giving you impression that he's already diagnosed with the asthma, right? So you need to acknowledge the emotions. Patient is saying, doctor, feeling short of breath. My asthma is killing me. Please help me. So you need to say, I can see you're short of breath. Please bear with me. My name is XYZ. I'm going to help you. So are you Mr. XYZ? Yes. So could you please tell me since how long you're feeling this way? He can tell you anything. So patient will be acutely ill, so you have to follow the ABCD protocol. Right. And okay, so in acute asthma session, data will be talking mannequin, patient breathing very heavily, monitor will be attached with the patient. So initial vitals, blood pressure will be stable. Ignore this blood pressure. In Simman station, blood pressure will be stable in acute asthma station, right? Heart rate, patient can be tachycardic, patient can be hypoxic, saturation will be low. Respiratory rate will be on upper side, almost double, right? So you have to follow the ABCD approach and just pick the findings in the monitor and verbalize those findings in front of the patient that I can see your saturation, the blood and your respiratory rate is high. So I would like to give you oxygen. Before that, you need to make sure the patient doesn't have any smoker's cough or COPD. Right? After doing the grips and excuse yourself, look at the monitor. If the patient is unstable, stabilize the patient first. If you are taking the history, it will not be a good thing, will not create a good impression. So stabilize the patient first. Only then you can take the history. If patient is talking in sentence, you can say, I can say, my patient is talking sentence in airways patent. And if patient is saying verbalizing anything in broken sentence, so you are supposed to check the airway, look any sign of obstruction or any sign of angioedema, right? The second thing you will be doing, breathing. So you have to look at the monitor for the oxygen saturation and respiratory rate. So respiratory rate is high in this station and saturation will be low. So you have to follow, you have to stabilize by giving the high flow oxygen 15 liter per minute with the mask attached. You have to verbalize completely, full sentence. I'm going to give you high flow oxygen 15 liter per minute with the mask attached, with the bag mask with bag attached, right? And if then you can ask the patient, please take nice and easy breath. Please tell me how are you feeling now? If patient is saying still short of breath, so you need to examine the chest. Second option, auscultate the chest. Before auscultation, verbalize, I'm going to have a look on your chest, and during the examination, I'm will be looking at your chest. I will be tapping your chest and I will be listening your chest sound, and I will ensure your privacy and chaperone will be with me. Would that be all right? If patient is giving you consent, then remove the duvet and start doing your assessment. And while you will be doing the auscultation, you will be actually hearing the wheeze sounds. Once you realize your patient having wheeze sound, you will change the oxygen mask to the salbutamol 5 mg nebulization. So still you will be giving high flow oxygen along with the nebulization, and you need to put salbutamol 5 mg in the nebulizer mask. You have to give the impression to the examiner, right? And the most important thing we discussed, the chest X-ray and ABGs, you can look at these things at this stage. That I would like to run chest X-ray and ABGs for my patient because I can see my patient is hypoxic. And once the patient is stable, only then you can move to the next option. If patient after giving the salbutamol, patient is still short of breath, the next option you can follow the ipratropium bromide, right? Ipratropium bromide 0.5 mg. If salbutamol is not helping, and you can keep on going salbutamol and ipratropium bromide cycles, and only then if still patient is short of breath, it's not helping, then you can move to the circulation because you have to give some IV medications. It could be hydrocortisone or magnesium sulfate later on. So you look at the monitor for the blood pressure, pulse and ECG things. And if those are stable, in this station, patient will be tachycardic. So tell the patient that I can see monitor your heart rate is very high. Your heart is beating very fast. Blood pressure will be stable. You can check the capillary refill time. You can check the pulse. Put large bore IV cannula on suitable side. It could be orange or gray, which we discussed before. Then give IV hydrocortisone 100 mg, right? Then once again, you can look at the monitor. IV hydrocortisone is helping or not, and you can once again auscultate the chest for the V's. If still V's are there or if it is improved. If it is not improved, uh, the ipratropium bromide we discussed before, you can give ipratropium. Then once again, after doing each and everything, auscultate chest once again. At least you need to check uh, chest one or two times after doing these management things. If still patient is short of breath, IV hydrocortisone, ipratropium bromide is not helping. So examiner can say, doctor, we don't have ipratropium bromide here. What will you do? So if you haven't give the hydrocortisone, you can give the hydrocortisone. And if still patient is short of breath, if still these are there, so examiner can ask you, what will you do now? So the next option is IV magnesium sulfate. It could be 1.2 gram or 2 gram IV over 20 minutes. You can give IV magnesium sulfate in the infusion form. So while give the IV magnesium sulfate, you can take your seniors on board. So I'm going to give my patient IV magnesium sulfate, and I would like to inform my seniors as well, right? So here at this stage, oxygen saturation can be improved 94 or 96. Then you can take the history, very focused history, what were you doing, and since how long you're feeling short of breath, does it happen before? You mentioned the asthma, could you please tell me about the asthma? You can take history about the asthma, when it was diagnosed, how it has been managed, are you following your chest specialist regularly, and are you allergic to anything, do you have any chest pain, are you feeling any thumping sensation in the chest, are you running any fever, any calf or leg pain, any history of trauma, any traveling history, you can ask these things, right? And you can do GCS quickly if you want. And so acute eczema patient can be stable or unstable, but most of the time they will give you unstable patient. And if the patient is stable, you can take the history, OD of short of breath, and some DDs to rule out COPD, pneumonia, myocardial infarction, pulmonary embolism. While doing the traveling history and asking about any leg problem or cough pain, you are ruling out pulmonary embolism. And by asking any chest pain, any sweating episode, you are ruling out MI. If you are asking the fever, you are ruling out pneumonia condition as well. And COPD condition, you need to ask it before giving the oxygen, right? Then past medical history, drug history, allergies, it, and what you are doing, tell the patient your oxygen is low, I'm going to give you high flow oxygen. Before that, can I ask, do you smoke a scuff, have you ever been diagnosed with COPD? Look at the rest of observation, verbalize examination, do inspection, palpation, percussion, auscultation, then management, perform investigation, the most important thing, 12 lead ECG, chest X-ray, ABGs, PFR, blood test while putting the IV cannula, full blood count, urea electrolyte, LFT, glucose, inflammatory markers, and at the end involve the seniors, admit the patient under the medical team, discuss with the ITU if the patient needs aminofiling. So this is all about the asthma station. So if your task say after 6 minutes go to the examiner, so ex- give the handover to the examiner by following SBR approach. So your examiner can ask any question. So make sure you are giving the situation, background information, asthma, your assessment by following ABCD protocol, what you have done so far, and recommendation, what would you like to do, what's your impression, and what's your further management plan, right? And at the end, you need to document everything what you have done. And once your patient is stable, you need to consult the patient about medication, about risk factors like carpet, any pets at home, any weather changes recently, if he's sensitive to anything, if he allergic to anything, right? So all those things you can discuss in the acute exacerbation of asthma. So this is all about asthma. If you have any questions, please write down in the chat box, or otherwise can't see the screen of your explanation. Screen is not visible once again, right? Asthma is always unstable. Visible is okay. Asthma is always unstable. Simman, right? Yes. Most of the time, your asthma patient will be coughing. He will be acutely short of breath. So he will not be able to give you history. Make sure you are doing ABCD protocol. You are trying to stabilize the patient. Only then you can take the history. Very focused history. In focus history, you can rule out differentials. You can ask about the risk factors. You can ask about the asthma condition, previous other medical condition, and most other things. All these things. So if you are doing these things appropriately, definitely you are going to get very, very good marks. So do you have any other questions? You can write down in the chat box. Any other questions? Okay, let's talk about another scenario, anaphylaxis, very quickly. We have some time. So there are three scenarios are coming in: blood transfer reaction, anaphylaxis reaction, penicillin allergic, anaphylaxis adverse reaction. So it can become with different scenarios. Okay, so blood transfusion reaction, you are FI2 in the surgical department. Mr. David Green, 56 years old man, had operation done 3 hours ago. He was transfused 1 unit of blood, currently receiving his second unit of blood. He's currently having sort of breathlessness. The nurse has called you to see the patient if she's worried about him. Please assess the patient, discuss management with the patient. Opening sentence can be, I don't know, doctor, but I am not feeling very well. So patient will say, doctor, I'm feeling unwell. Patient will say, doctor, I am short of breath, my lips are swollen, my hands are itchy. So anything like this. Just make sure you're picking the verbal cues and you're reflecting back. And patient can ask you in the mid, what is wrong with me, what's been going on with me, what are you going to do for me? So these could be the questions. So once again, following the ABCD approach, so initial vitals would be blood pressure will be low, heart rate will be tachycardic, saturation will be 88, or respiratory rate will be 30, right? And if you are doing the resuscitation correctly, so blood pressure can be stable, heart rate will be normal, and saturation can improve to the 92, right? So other findings, patient will be unresponsive, oxygen face mask. You can give non-rebreather oxygen mask in the first place, and there will be transfusion, ongoing transfusion. So once you realize your patient having anaphylactic shock, you will stop the transfusion, which is ongoing. You will not remove the transfusion. You will just stop the transfusion by keeping down wheel of uh, drip set. And the normal saline, there will be need of giving normal saline 0.9%. There will be need of giving nebulizer mask. So there will be nebulizer mask Once you realize on auscultation your patient having wheezing sound, you will change the mask and the blood pressure will be dropping. So you need to keep the normal saline and IV adrenaline 0.5 mg. So once you are doing both things, the blood pressure will goes back to normal, right? Saturation will be at 4. So if you are giving oxygen mask and nebulization, saturation can improve back to normal. Okay. Okay, so approach is same ABCD protocol. If unstable, the thing is you need to stabilize the first. We need to repeat hydrocortisone or hypertropium. I mean, stop the examination and get back to repeating medication. And acute limb ischemia should be cured if the saturation drop while taking the history or doing examination for disability. If the saturation is dropping, so you don't need to do examination, you don't need to take the history, stabilize first, right? In acute limb ischemia should be give painkiller first after assessing airway and asking allergy. Take focus history, Socrates, do some differentials, only then you can give painkiller. So it's not recommended by the GMC. Don't give painkiller in the first place. Take very focused history. Ask the patient, please be with me. I need to ask very important history, and then I will be giving you some painkiller depending on your condition. Do we need to repeat hydrocortisone or ipratropium? In some situation we can, but if hydrocortisone is not helping, the next option is IV magnesium sulfate. So your examiner would like to know either you know about IV magnesium sulfate or not. I mean, stop the examination and get back to repeating medication. Yes, you can repeat the same medication, but it's wise. Before even starting ABCD, we will stop the blood. So once you realize your patient having short of breath because of receiving blood transfusion, you can stop the transfusion, right? So you can do it in the first place. If you see patient is feeling unwell, patient having swollen lips, you can say, I can see you are receiving some blood products, so I'm going to stop at this moment. So stopping blood transfusion is not going to harm you, right? So first thing, stop the blood transfusion, check the airway, look for the sign of angioedema, any sign of obstruction. Then if airway is patent, then go to the breathing part. Saturation will be low, respiratory rate will be high. So start doing your assessment by giving high flow oxygen. The same thing we did in the asthma condition. Then change the mask to the salbutamol once you realize there are some wheeze sounds while auscultating the chest. And meanwhile, you will be verbalizing chest X-ray, ABGs for your patient. And once you realize the saturation is low, respiratory rate is high, patient is having itchiness, swollen lips, and it could be the rashes over the chest or it could be rashes over the thigh area as well. So once you there are sign of anaphylaxis, only then you can give 0.5 mg IM adrenaline, and you can repeat it every 5 minutes. Patient is not improving, right? So these days, chlorpheniramine and hydrocortisone is not recommended. But if IM adrenaline is not helping, you can give chlorpheniramine 10 mg for the rashes and hydrocortisone as well. In circulation, the patient will be hypotensive. So check blood pressure, check the capillary fill, pulse, blood pressure, and check the ECG. Auscultate the heart sounds as well. Put 2 large bore IV cannula on suitable side. Run some investigations and 12 ECG as well. And full blood count, liver function, electrolytes, serum lactate level. Make sure patient is not developing any sepsis. So you can give bolus normal saline 500 ml, and you need to actually put the normal saline near to the patient's arm, right? Or if there is any stent, you can hang it on the stent, and then you can do the GCS thing. You can ask quickly, where do you? Can you please confirm where exactly you are? And can you please open your eyes and keep it open for me, right? And can you squeeze my finger, or can you please raise your arm? You can ask these things. And observation. So red flag things, once your patient is stable, you can take very focus history. Any pain anywhere, any chest pain, any itchiness, are you able to swallow? And you can ask the patient, did you receive any medication? Are you any allergic to anything? So in penciling allergic patient can tell you that doctor, I received some medication and I am not aware of those medications. So as a safe doctor, you need to open the documents, patient documents, and double check with the nurse colleague if either patient received right antibiotics or not, and if patient having any history of allergies, right? Then do Maftuza past medical drug history, allergies, and while running the investigation, you need to send the same blood sample, and you need to do the group match, cross match once again, and you will send the same blood products which patient is receiving to the laboratory, right? And you can involve the hematological team as well, or allergic specialist. So diagnosis, you can tell the patient it seems like you are having severe allergic reaction, unfortunately, and it 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 seemed like it's started after receiving the blood products you have. As a doctor, we call this condition anaphylaxis. We have give you antidote for the allergy and something to relieve your itchiness. You can say these things. You will need to be admitted, and if patient can have three allergies, so it could be allergic to blood transfusion, any antibiotic, or any drug allergy, or patient may be having any latex allergy. So you can confirm the patient did it start after you were put catheter, or after receiving blood products, or after receiving any medications. So you can confirm these things by asking questions. So in management, send the blood back to the hematologist, routine investigations, ABGs, ECGs, chest X-ray, and document everything what you have done. And if it is written that after 6 months you need to talk to the examiner, so give SBR approach and tell the examiner what you're finding and what you are being suspecting. So always involve the senior and critical care team. If they suggest anything, you can uh, make some changes in your management plan. So it's all about anaphylaxis. We have only 2 minutes time. You can quickly write in the chat box, or you can ask on the WhatsApp group we have. So this session is all about Simman, anaphylaxis. I mean, stop examination, get back to repeat medication. Yes, once your patient is unstable, leave everything and start managing him once again. Before even start ABCD, we will stop the ABCD. Yes, there is no harm. You can, once you talk to the patient is feeling unwell, and you see patient is receiving some blood products. So there's no harm. You can say, at this stage, I can see you are receiving some blood products. So it could be related to this. I'm going to stop it. We will give salbutamol if we heard crackles in anaphylaxis. So most of the time you will be able to hear wheezing sound in anaphylaxis. Can you share these notes in the group? Yes, definitely, Dr. Maria. We have already shared, but I will share it once again. So guys, this is all about Simman station, and we have left some station. We will be discussing those station in next time. And please leave your feedback in the WhatsApp group. And if you have any other difficulty in Simman station, we will be arranging another session very soon. Do we give salbutamol in case of heart failure, Simman? So why we are giving salbutamol? Only you will give salbutamol in which you have hear the V sounds. So in heart failure scenario, if patient having V sound, you can give salbutamol. So it's up to you. So being a doctor, you need to check chest carefully, and if you are hearing V sounds, you can give salbutamol. Please, doctor, how can I join the WhatsApp group? Uh, we have a